Thank you for joining us for today's important and informational webinar. Today we will be joined by Robert Greenwald and Carmel Shakar from the Harvard Center for Health Law and Policy Innovation, who will introduce us to important new tools to fight HIV health insurance discrimination. Before we begin, we have a few housekeeping items to go over. All participants are in listen-only mode, but we encourage you to use the question feature on the right side of your screen to ask questions throughout the webinar. We will answer questions at the end of the presentation. If you are unable to hear the audio, you can dial in using the telephone number and access code provided on the audio control tab on your computer. We also encourage you to download the slides after today's webinar. They will be available both in a follow-up email and on hivhealthreform.org. You can also follow up and live tweet during the webinar using the hashtags HIV and ACA. We also encourage all participants to visit our website, hivhealthreform.org, to find the most important up-to-date information on the ACA and its impact on the HIV community. You can read our blog, access our email newsletters, and find more information on both previous and future webinars. Lastly, we encourage folks to use the Speak Up feature on hivhealthreform.org to report problems they or a client may have experienced while enrolling in a healthcare plan, accessing a health network, or paying for medications. Through Speak Up, we are able to identify patterns of discrimination emerging that need to be addressed, educate state and federal officials about what's happening on the ground, advocate for change, and report back to the community. At this time, I'll pass it over to Robert and Carmel for their presentations.
Thank you. Hello, everyone. Welcome to our webinar on a new tool for fighting health insurance discrimination, complaints to state insurance commissioners. Now, today's webinar is one of a series of webinars we're conducting in collaboration with a team of national organizations in an effort to address the discriminatory insurance practices that people living with HIV and other serious health conditions are experiencing in both public and private health insurance. With today's webinar focused on the private insurance sector and what we can do to address the range of discriminatory practices we are seeing in this sector. Today's webinar focuses on complaints to state insurance regulators because we are consistently hearing that internal appeals to the insurance companies themselves, while a necessary first step, are often not working very well. So a few examples. Some insurance plans don't have grievances or appeal processes in place. Other plans often just reaffirm the original denial without a review of the real facts of the case. And others simply just don't respond to appeals or grievances. I have to say all of these practices are in fact prohibited under the law. But because of this, when this happens, the next step is not to just give up, even though that's an understandable response. Instead, we have to take our concerns to the next level, and that's what this webinar is about, filing a complaint with insurance regulators who are charged with monitoring insurance practices and enforcing anti-discrimination laws. This webinar will provide us all with the information we need to file such complaints to state departments of insurance to fight HIV insurance discrimination. It will walk us through each step in the process of completing newly available template complaint letters, and it will discuss next steps in our efforts to reduce discrimination. While we know we are all preaching to the converted here, as you're on this webinar today, it's really important that we educate as many people as possible in the HIV community as to the importance of filing complaints when discrimination is taking place. And there are two primary reasons that it is so important. First, complaints to insurance commissioners have been proven to be a powerful tool. There are examples where it results in significant regulatory changes. And throughout the webinar, we're going to provide examples of such changes. But second, and this is as important, even if the complaint is initially unsuccessful, it can help to educate the insurance regulators. And when they get enough of those complaints and understand the issue, it can result in a successful law reform effort. It also helps for us to build the case if litigation becomes necessary. So really, for combating insurance discrimination, this is an important step in the process. Next slide. So now I'm going to briefly describe why insurance complaints are so crucial in a bit more detail to improve healthcare access for people living with HIV. Next slide. As we all know, people living with HIV are experiencing a broad range of discriminatory practices in private health insurance plans. We're not going to go into very much detail because we're really focusing on insurance complaints and the template, but it's all that we've been hearing about in terms of transparency, coverage, and cost, right? Unfair or disproportionately high cost sharing that makes it impossible for some people living with HIV to pay for their health insurance. In some cases, people are finding that there's no coverage for the medications that they need or the services they need. And then there are, again, the process issues, either the failure to have an adequate appeals and grievance process or issues around transparency where it's just impossible to find out what services are covered and at what price. Now, the good news is the Affordable Care Act includes some new, strong anti-discrimination provisions. In some cases, the law specifically prohibits discriminatory insurance practices that were, in fact, in the past, rampant, that we were constantly seeing. For example, the law used to allow people being charged higher premiums based on a person's health status. People were denied coverage for pre-existing conditions, or there were annual or lifetime limits on coverage. We're still seeing some of those practices, but the ACA is now clear in statute that these are all prohibited practices. Now, in other cases, while less specific, the law also includes new general anti-discrimination language that's similar to other federal and state laws, protect against discrimination that is geared towards those with a particular health condition or unfairly denies access to medically necessary services. Filing complaints with insurers enables us to establish clearly that the Affordable Care Act and other laws provide broad protections against the kinds of insurance practices people living with HIV are confronting in new insurance plans. So it's really important that we set the precedent early and often that the laws prohibit the kinds of things that we're seeing in these insurance plans that are all but denying people living with HIV adequate access to care and treatment. Next slide. So why are we targeting our advocacy towards state insurance commissioners? First and foremost, state insurance commissioners, regulators, have always been responsible for frontline oversight of the health insurance industry, and the Affordable Care Act retains this system. While under the ACA, the federal government has some oversight responsibilities, state insurance regulators are still charged with frontline oversight. With the ACA, state regulators must now oversee two insurance markets, the traditional health insurance market and the new Affordable Care Act marketplace or exchange, and all the plans that are sold on the marketplace. And in addition to anti-discrimination provisions, there are also new laws that they must enforce for the marketplace plans. So the ACA, for example, establishes that any plan that's sold on the marketplace must provide essential health benefits, which include, for example, access to prescription drugs. They must have network adequacy, making sure that the providers that we need are part of the plan. And they must perform uniform and transparent information about coverage. So again, because these new provisions are part of the ACA, when these plans fall short of meeting essential health benefits, network adequacy, or transparency, it is the insurance regulators in the states that are the first stop for enforcing that these types of practices are changed. Now, some states' insurance regulators are actively engaged in their new ACA responsibilities, and they're starting to enforce the transparency and coverage requirements under the ACA. The problem is most states have not sufficiently changed their insurance regulations or oversight in response to the Affordable Care Act. So this is what the complaints are about. Division of Insurance Complaints will put pressure on state insurance regulators to update their regulations to meet the new Affordable Care Act oversight responsibilities as required under the law. And if they don't, we'll then have the record to prove that we've done all that we can to hold them accountable. And then we can turn to the federal government, who has the ultimate oversight responsibility for the marketplace, or to federal and state courts that are also responsible for holding state insurance regulators accountable when they're not enforcing the law. Next slide. So we're about to start looking at the complaints themselves, and Carmel Shachar on the team here at Harvard is going to move you through that. But I need to reiterate the most important point. It is extremely important that our state insurance commissioners receive complaints from us that demand an elimination of discriminatory insurance practices. In some states, again, we have sympathetic commissioners, but they're saying they need consumer pressure in order to effectively regulate their insurance markets. Many are saying they have not received any complaints from the HIV community documenting discriminatory practices. And if they have that information, it would make it much easier for them to enforce the laws against their insurance coverage plans in their states. We need to give the insurance commissioners who want to help us the concrete information and political cover they need. So we need to provide them with concrete examples of discriminatory practices and how they are harming real people living with HIV and living with other health conditions. And for those insurance commissioners who don't want to do the right thing, the lack of complaints lets them off the hook. It allows them to ignore the discriminatory actions that are taking place on the part of their local health insurers, and they get to say, I'm not receiving any complaints, so there must be no discriminatory practices happening. We need to file complaints, and then if the insurance commissioners fail to respond, we need to go over their heads, again, if they try to ignore us. We must ensure that our insurance commissioners in every state hear from us, and they have to feel the pressure to stop HIV-related health insurance discrimination. I'm now going to turn this over to Carmel Shachar, our staff attorney at the Center for Health Law and Policy Innovation of Harvard Law School, to provide more information on when, why, and how to use the new available health insurance complaint template. Thank you.
So, hi everyone. I hope you're having a good afternoon. As Robert said, my name is Carmel Shachar, and I'm here to help explain how to use the DOI templates, when it's appropriate to use them, and just to walk you through how to actually use them. So next slide, please. So when we drafted the DOI template, our target audience was really State Department of Insurance and insurance commissioners. However, that's not to say that the target audience can't encompass more people than just those regulators. So for example, in some states, there's a significant overlap between the departments of insurance as well as the state equivalent of health and human services. So you may want to consider whether in your state, is the Department of Insurance really the one actively regulating the insurers, or is it the Department of Health, and adjust accordingly. The DOI template is intended to support the development of grievance letters from advocates and providers to state regulators. So the longer letter is really intended to come from a provider, from an advocate, somebody who has a very good understanding of the issues. That's not to say that consumers can't use these letters. If they feel comfortable, they should feel free to adapt the letters and send them. However, we did also create a version that a consumer who may not have as strong a grasp on the scientific background or on the legal and regulatory and policy background could feel more comfortable using the shorter letter to send. And we'll get to the shorter letter in a little bit. The DOI template, as I mentioned, was drafted to send to state regulators as the target audience. However, we have had some success adapting these templates to send directly to insurers. In particular, we've seen success in states such as Louisiana, in which one of our partners adapted the template to send to Blue Cross Blue Shield over the mail order pharmacy issue that Blue Cross Blue Shield was putting all of its HIV medication in a category that required use of mail order pharmacies, and that consumers weren't able to get these medications directly from their brick and mortar pharmacies. The letter was adapted, it was sent out. Blue Cross Blue Shield of Louisiana was very receptive to the letter and came back and changed its policies. Another way that you can loop the insurers in, and we recommend it, is that you can consider copying relevant insurers on the letter to regulators to give them notice that you're sending this letter. And this is good because it really does put the regulator on notice that you're making sure to publicize this, you're not being very quiet about it, but it also gives the insurers notice that, wow, you're serious and you're pursuing every sort of avenue of grievance to make sure that your voice is heard. If you want to modify the template to send directly to insurers, this can be a little bit tricky. So what I would recommend is that you give us a call. My contact information is at the end of this presentation, and we're happy to either walk you through what would need to be modified or to help you modify it so that you can send it out to insurers. Next slide, please. When to use the DOI template. So when a lot of people think of legal advocacy, they think of litigation, the kind of law and order during a courtroom. And the DOI templates are not litigation, although we believe they can be used either instead of or to complement the litigation strategy. They're regulatory advocacy. So the main purpose of these template letters is to create letters that will draw the regulator's attention to consumer issues as opposed to filing in court. One advantage that pursuing a regulatory complaint may have is that it's a little bit less adversarial than our legal system. And especially in a situation where you may have to work with insurers on other projects and you don't necessarily want to create as adversarial a relationship as filing a lawsuit against them may trigger, you may want to consider doing a regulatory complaint. Also, regulators, it's no secret our courts do move a little bit slowly. I think people can often be frustrated and surprised by how long it takes. Regulators at times have freedom to move a little bit more quickly. They can issue regulations and get them implemented much faster than getting on a docket and moving through all the motions and getting a court case to come to its final resolution. However, that's not to say that a regulatory complaint is always the best option or that by sending it off you can avoid long, difficult, costly litigation always. We've heard from some regulators who are even sympathetic to our issues that they just need the pressure of litigation to provide political cover in order to respond effectively. In fact, this issue has come up time and time again with the U.S. Department of Health and Human Services, who say, you know what, we hear your complaints, we hear the concerns, but we can't really move forward on stronger regulations until some litigation is starting to bubble up through the system and we can present this to the powers that be. So it depends on the regulators. You may, as state-based advocates, have a better sense already of whether the regulators will be receptive to the complaint letters or whether litigation will be a necessity. But again, we're happy to support you, and please give us a call if you want to discuss these issues. Next slide. So why use these templates? These templates can be used to address a variety of issues, and I know that Robert mentioned some of them, but I'll just go through the list. So it can address the fact that insurers aren't covering important HIV medications, that insurers are changing coverage after the end of open enrollment in a sort of bait and switch manner. Insurers are practicing adverse tiering, which means, for example, they're placing all HIV medications in formulary tiers with high cost sharing, such as putting them all in the specialty tier. It can address when insurers are requiring really onerous prior authorization or other kind of medical management requirements for HIV medications. It can address when insurers are requiring use of mail order pharmacies for HIV medications. One thing there I'd like to note is that because of federal regulations, that's going to be an issue less and less moving forward in 2016 because federal regulations are going to go into place requiring that even if you do use mail order pharmacies, that consumers will have the option to get their medications from brick and mortar pharmacies. The only issue is insurers are going to be allowed to do a cost differential to make mail order pharmacies cheaper. So there may be some work to make sure that the cost differential is reasonable and not so great that effectively it's requiring consumers to use mail order pharmacies. I want to emphasize that really the most effective and well-received letters are those that are as specific and as detailed as possible. And what I mean in that is that when you send these letters, try to give as much information as possible. include the medication names, include the denial of coverage date, attach as much documentation as you can. You're going to want to be sensitive around people's personal medical information. You may want to redact names if the consumer doesn't feel comfortable using his or her name on this complaint. And that's, again, something, please feel free to give us a call to talk through any medical privacy issues. But really, regulators are going to want to see as specific information as possible so that they can really verify that this issue is occurring. Next slide. Continuing through how to use the DOI template. So the way we've constructed it is that there's a lot of fill in the blanks. Wherever there's a fill in the blank, we've highlighted it yellow to help catch your eye. The first page has by far the most yellow on it, although the last page does as well. All of these are fields requiring your input. You can use the letter to highlight multiple complaints. You don't need to send this letter for each separate issue or for each separate patient. And I'm going to include this warning just because this is the kind of mistake that I would absolutely make. Definitely double check to delete inapplicable material. For example, on the first page, we include a host of issues that you can use this letter for. They're not all going to be relevant for your complaint. Be sure to delete them. I know that sounds really rudimentary, but that's exactly the kind of thing that I do. So I just wanted to give you guys a heads up. Next slide. So the next section is really kind of the thesis statement of this letter. So it strongly states that the protections that we're asking for are guaranteed in the ACA. And really what we're finding is that state regulators must be reminded that insurers are prohibited from discriminating against consumers on the basis of disability. Not every state regulator is going to be as knowledgeable about the ACA and its requirements as they should be. And I think that Section 1557, the anti-discrimination section, can get a short shrift among state regulators. So this really is trying to draw their attention to that fact. I'd like to note that this section is really specific to health plans offering the marketplace because it discusses EHB. If you have a complaint that's related to an employer-based plan or to a Medicare Part B plan, which we're seeing more and more complaints, please again contact us for help modifying the template because it can be a little bit tricky, and we'll be happy to do so for you. One thing I'd like to note is that these templates are what I like to refer to as living documents, in that there's always a chance that new regulations will come up either on the federal or state level that will be relevant and should be incorporated into the letters. For example, we've heard rumors that there'll be some regulations issued on the anti-discrimination provision by the Department of Health and Human Services. If that happens, we're going to work to update the letters. So you should be aware that we will continue to update the letters as necessary, and I'll discuss how to be aware of that in a couple of slides. Next section. So the next section is sort of the doctory medical section, as I so scientifically refer to it. Most state regulators are not going to be familiar with current HIV standards, and they're not really going to understand what they are. And they may not even be aware that the Department of Health and Human Services publishes guidelines on HIV treatment. So this section, what it does is it really walks through for the regulators an overview of the HHS guidelines and lets the regulators know, hey, there's a clear benchmark in the treatment for HIV. So we know what these plans have to offer in terms of healthcare access, and if they're not facilitating that, they're missing the mark. They're not being a good plan for people living with HIV. Next slide. So that gets picked up in the next section, which discusses in depth the federal anti-discrimination regulatory language that's both in the ACA and then has also been published in the Federal Register by Health and Human Services. So these aren't necessarily codified as regulations, but it's language that HHS has issued saying if you put all of your medication for a chronic condition in the highest cost sharing tier, that's discriminatory practices because you're dissuading these people who have this chronic health condition from enrolling in your plan, and it should be considered discriminatory. Again, these regulations can be subject to change, and if new regulations come out with good language or a court case comes out that may impact this, we're going to be staying on top of it and really updating it. So while this is right now the cutting edge thought distilled on the anti-discrimination provisions, it may not be in the future. So really keep an eye out to make sure you're using a current version of the template. Next slide. So as I've mentioned, we also created a consumer DOI template. And this is because some consumers may not have the background to feel comfortable with the scientific and legal language of the DOI template as it stands. For these people, we've created this consumer template, which is shorter. It's about 3 pages as opposed to 7. It has minimal citations, which makes it a lot more approachable. It has an extremely abbreviated standard of care section, and it has a shortened anti-discrimination mandate section. Now, again, this is not to say that a consumer who reads the longer template and feels comfortable with it can't use it. They can absolutely use it. But we offer this as a resource so that if you as an advocate or you as a provider are working with consumers and you don't want them to sign something and send something that they don't understand or feel comfortable sending. So if they read the longer one and they say, you know, I don't understand this is too much language, it feels overwhelming, you can give them this shorter template. In addition, we're working on several other related templates. So for example, we're working on a very similar template that's going to be hepatitis C specific that should be coming out hopefully shortly. We're also working on a generic non-disease specific template that somebody will be able to take and maybe adapt for diabetes or heart disease to reach those other communities. What we're also hoping to do is we're hoping to generate template appeal letters for providers to use specifically with insurers. As sort of the first step, you've sent off a request to get somebody a certain medication, and the insurer comes back denying that request. Well, here's a template letter you can use. And here I'm going to do a plug for the development process there. If any providers are on, or anybody who works with a lot of providers are on this call, we're looking for those denial of coverage, denial of access letters so that we can write these templates. If you have access to them, please consider sending them to us. You can redact the patient information so that there isn't to worry about patient confidentiality. And again, give me a call if you feel nervous and I can walk you through how to do that, because really the best way for us to generate those template appeal letters is to see what kind of letters you guys are getting. Next slide. So I've walked you through the DOI template, and what we're now going to do is we're going to sort of give you a little more context, walk through next steps, discuss some tips about using these templates, and then I'm going to take any questions that people might have. Next slide. So just to give you some friendly, helpful tips for using these templates, always download a fresh copy of the DOI template, either consumer or the one for advocates and providers, from a variety of websites that are going to be hosting it, including my center own, from HIVhealthreform.org, where it'll be posted shortly, or from HIVMA's website. And again, I've been emphasizing that these are living documents, they're subject to change, and especially if new federal regulations are issued. And so the websites will always have the most recent version. So I wouldn't recommend downloading a copy this week and saving it to your hard drive and using only that. Just go to the website, download a clean copy every time you want to use it. Consider contacting us when you decide to use the DOI template. Since we wrote it, we're obviously very familiar with it, and we can help you better tailor the template for your needs, especially if you want to do anything a little bit unusual. Also, because we'll be hearing from other people using the template, we may be able to give you insight into what other providers, advocates, and consumers in your state have done. So it may be helpful for you if you give me a call and I say, you know what, we've been hearing a lot of complaints against Humana in your state, and here are some other advocates sending letters. Do you want to coordinate with them? So even if you don't want our help, because these templates are really designed that you can use them without a lawyer sitting there guiding you through each step, let us know anyway that you're using the templates. Not only will it be personally flattering to me, but it'll be helpful to let us know which regulators in which states are facing pressure so that we can better coordinate other advocacy as well. So please share this resource widely. The more the letters, the more powerful the impact. That's absolutely true. We want regulators to get a lot of these letters so they pay attention to it. One thing that I know is going to happen is that this webinar is going to get posted online as a video. So if you have a fellow provider, a fellow advocate, or some consumers, if you want to get trained on how to use this template, you can refer them to the video. Another thing is if you have a bunch of people, let's say that, you know, a bunch of AIDS service organizations that for whatever reason weren't invited or couldn't make it, please feel free to contact me and we'd be happy to set up a webinar for them so that we can help train them. We really want this to be a very widely available resource. And somebody, even if it's somebody who doesn't have the time to sit through the webinar, forward them the link, please. Next slide. So next steps after you use the DOI template. You've used it, which is awesome. You sent it off. Now what? So we recommend that you send your complaint electronically and in hard copy. I am young enough that for me, I find paper mail to be utterly annoying. Some regulators are like that. They want to see things in email so they can forward it. It doesn't exist hard copy. Other regulators are a little more old school. They may get their email, they may read it, but a letter is going to be more helpful. That's why we recommend sending both. Additionally, if you send it in an email form, and we recommend sending it as a PDF connected to an email with a cover email on top of it, then sending the hard copy is kind of a good follow-up. And you can modify the hard copy to say, we sent you a copy of this letter on X date, this is a follow-up. We would also recommend following up within a few weeks to confirm that they've gotten the letter, either electronically or in hard copy, and then offer to meet with the regulators to discuss the letter. So again, we recommend letting insurers know that you're sending information to regulators so that they themselves will feel the pressure. You can copy insurers on these letters, you can send them a separate letter, and you can offer to meet with the insurer. Say, hey, we're sending this complaint to the Department of Insurance. Do you want to meet to discuss your practices before we meet with the regulator? And you may find that they're more willing to work with you now that they know that you're willing to go complain to the regulators. You can consider litigation strategy in tandem with regulatory complaints and appeals. Sending this letter doesn't mean you can't also do a litigation strategy. Litigation can be slower and costlier than regulatory complaints, so I think it's better to send off the regulatory complaint as the opening shot and then maybe consider looking into litigation as opposed to look into litigation and hold off on sending the regulatory complaint. But certainly you can coordinate using both of those at the same time. Next slide. So we've now reached the end of our talk about the DOI templates, but I welcome any questions you have, and my contact information is at the very end of the slide deck. Please feel free to reach out to me either by phone or email, and I'm happy to walk you through any more specific questions that you may not feel comfortable asking on the webinar. So,
great, thanks, Carmel. So I am going to moderate the questions and just jump in at any time to provide answers. So the first question here is about deductibles. So question, is it legal for the deductible to start over after it has been met if someone loses coverage due to not providing additional documents requested by the marketplace?
So that's something that I think may be helpful to talk offline, and whoever asked that question, please reach out to me because it sounds like something very specific happened there. But in general, if you've lost coverage and you're re-enrolling and it's considered a separate plan, the deductible does start over because it's not like coverage has been put on pause for a couple months and then started again. It's that you got kicked off your plan for not providing enough information, and then once you provided enough information, you essentially started a new plan.
Great, thanks, Carmel. The next question, there's a couple here about network for medication access. So just a couple questions about this practice of narrowing the networks and the use of specialty pharmacies or mail order pharmacies. Someone noted that many patients currently are receiving their meds via mail order, but they don't want to for privacy purposes, and they're curious if this is illegal for insurance companies to influence patients and require that they do so.
So the answer to this, like all good legal answers, is complex. But at heart, like I said, there are federal regulations saying that for the marketplace plans, not right now, but starting very soon, starting in 2016, I believe, it will be a requirement that you can receive your medications either mail order or through a brick and mortar pharmacy. The catch is those regulations allow for a price differential. So an insurer can still say it will be cheaper for you to use mail order pharmacy. So you may still see a lot of pressure that way. Currently, it varies by state, and most states don't have a requirement that you have to have access to a brick and mortar pharmacy. We think this is entirely an appropriate complaint. So if you're facing this, even though there are the federal regulations starting in 2016, we recommend that you use the template to send letters to regulators to see if, first of all, they can do something that will start before the federal regulations start. They will do something that will eliminate the price differential the federal regulations allow. And then also remember those federal regulations apply to marketplace plans, and there's more plans than that out there. And the state regulations will cover also other non-marketplace plans. So even though federal regulations will take some of the pressure off this problem, you should still reach out and use this template to create complaints for the state regulators.
Thanks, Carmel. A question here about transgender care. Curious if you will be working on a template for discrimination against transgender care, similar to the one we have now.
So that wasn't something that we specifically had in our work plan, but I think that is a great idea. And again, absolutely, this sounds like somebody who might have more background in these issues than I necessarily do. So I would welcome somebody reaching out to me to discuss sort of the issues that the transgender community is facing so that I can make sure that we turn out a template that's useful for people facing these discriminatory practices and that is as sensitive and as appropriate as they deserve.
Great, and could you, to the best that you can, Carmel, maybe define or expand a little bit more about what we are talking about when we say things like discrimination of transgender care in plans? What are some of the discriminatory measures that might be found in those plans if people are looking at them?
Sure, so I think any plan where the financial incentives are structured to make somebody with a particular issue look at the plan and say, this plan is not worth it to me, is probably discriminatory. And I'm going to give examples from the HIV community because that's the community that I know best and work with. But if a plan has structured their pharmaceutical tiering to make coverage of pretty much all HIV medications just financially not feasible for the average patient, so they're saying, oh, we cover a tripla, but your copay will be 50% of the medication. The average consumer living with HIV is going to say, well, why am I even bothering to pay the premium? Because, yeah, you're paying 50% of it, but 50% of an expensive medication is still too expensive for me. What we argue are that plans are doing this very consciously because they want people living with HIV or people who are transgender to look at these plans and say, this one doesn't meet my needs, I'm going to go to a different plan. And that's discriminatory when they are constructing their plans on purpose to be unfriendly to people living with certain conditions so that those people don't pick their plans. So I think talking about people who are trans, if the plan is structured so that hormone therapy or any sort of treatments that somebody who is trans would want is so expensive as to be basically they might as well not have insurance, then that's probably discriminatory. That's probably a tip-off.
Thanks, Carmel. Next question here. Excuse me, I'm just pulling up. So just a comment here that most insurers are requiring brick-and-mortar pharmacies to acquire expensive accreditations before allowing them to dispense HIV meds. Very expensive, anywhere from $300,000 to $500,000 to obtain. And so this person's curious if this might be considered discriminatory or, you know, definitely a significant barrier to medication access. And curious about what can be done about this accreditation requirement.
Yes, so I think that is probably discriminatory. It'll take a little bit more sort of walking the regulators through the argument than it might be for just a more straightforward consumer complaint. So again, I know my answer is always come talk to me, but really, I'm really friendly, you guys. I'm really nice, and I'm really here to help you turn out the best complaint letters that can be turned out. I think if they're consistently making brick-and-mortar pharmacies jump through hoops to carry HIV medications that there's no medical reason for, because brick-and-mortar pharmacies have carried HIV medications beforehand, they're competent, they're licensed, they meet all the state requirements, then chances are they're doing that to make sure that there's no practical brick-and-mortar coverage of HIV medications. And that's discriminatory because they're, again, making themselves less attractive to people living with HIV. And so that's something we can work to create, I think, a strong complaint letter to send to state regulators saying, hey, you guys have set up the requirements for a pharmacy. We meet those requirements. And this insurer is systematically not letting us carry these HIV medications to serve a community. And therefore, they're getting a bad reputation. They're intentionally pushing people living with HIV out of their plan. And that's where you as a state regulator need to come in.
Great. Next question here is about Medicare Part D. Does the ACA anti-discrimination law apply to Medicare Part D plans? And if not, what law could someone look to evaluate and understand if parts of those plans or coverage might be deemed discriminatory?
So Medicare Part D is not a marketplace plan, so the EHB rules do not apply to them. But there are other components in the Medicare Act that do discuss discrimination. It's not quite as straightforward as the anti-discrimination provisions of the ACA, and I know, again, this has been my answer to everything, but send me an email, we'll set up a time to talk, and we can work through how to create a legal argument so you can use a similar complaint letter with state regulators, because I know through our other work in the Speak Up project, we've been hearing a lot of complaints from consumers enrolled in Medicare Part D about their treatment of people living with HIV.
Okay, next question here. Is it legal for insurance companies to apply only a portion of the cost for labs or something else towards the deductible? So an example is a circumstance where lab work was completed or medication was ordered, and of the total cost, I'm assuming that a patient pays, only a small amount was applied towards the deductible.
So I don't think so. If it's something a patient is paying out of pocket, it should count towards the deductible and what they're spending. So that seems like it would be a very appropriate complaint to put in a letter to state regulators that insurance companies are sort of doing this, I guess I'd call it tricky accounting, to keep people from hitting the deductible maximum and to charge their consumers more. It may not be specifically a discrimination issue if it's affecting everyone and not just people living with HIV, but if they're specifically doing it only for HIV services, or if the vast majority of this practice is applied to HIV services, then I think you'd have a discrimination issue.
Great, and continuing on our theme of tricky accounting, we have a participant in South Carolina who noted that they're seeing checks, I'm assuming premium checks, not being posted for 14 days after they receive the check, and then not allowing consumers to fill prescriptions because the check hasn't then been posted to the account. Could this be considered a discriminatory practice?
Yes. So I'm assuming these premium checks are from the state ADAP, and basically people living with HIV are lucky in some ways because the ADAPs exist and they cover in some states they cover the premium payments for marketplace plans, and they're really unique. They're one of the only third-party payments of premiums that we see. In Louisiana, for example, I believe it was Blue Cross Blue Shield for a while decided they weren't going to take third-party premium payments. And that was unquestionably a discriminatory practice because only people living with HIV had these third-party premium payments. So if this is the case, if they're being sneaky about cashing the ADAP checks to make sure that people are going a little bit long and not getting coverage, that's absolutely discriminatory. That's an appropriate topic for a complaint letter. If it's that they're being bad in general about cashing premiums, even if it's from somebody's private checking account, it may not be a discriminatory practice if they're doing it to everybody, not just people living with HIV. But again, that's something to complain to the state regulators about, because if people are sending in their checks on time, then the insurance company needs to honor that and treat it as if it's being sent in on time and provide coverage. So in both cases, I'd say it's worth a letter to the regulator. If it's specifically related to cashing checks from an ADAP, then it would be an appropriate discrimination letter.
And Carmel, this participant also raised the issue that they're seeing in South Carolina, that they're also seeing the need to obtain prior authorization for most new HIV meds on the market, Stribild, Complera, et cetera. So I believe, I'm going to say that we understand this to be a discriminatory aspect of a health insurance plan. But Carmel, I'm wondering if you might be able to walk through maybe what that DOI complaint letter would maybe look like, and what information would be included in terms of, why and how prior authorization is a barrier for HIV-positive individuals trying to access care and meds, and what information to include, and what information might not be helpful for a regulator looking at that?
Sure. So in the situations where an insurance company is overzealous about their prior authorizations, so they're really onerous, they take a really long time to process, they come back oftentimes with no, what I would do is I would modify the opening to explain this is happening. I would maybe try to give as many specific examples and sort of numbers and statistics as you can. So you can say something like, patient A tried to get this medication, their physician filed a request on this date, the insurance company took 3 months to get back to them and said no, thus creating a situation where patient A wasn't able to receive appropriate care for several months because of limbo. So you might want to say that. You might want to say we've heard of about 10 patients who have been denied after waiting a while this very common new HIV medication. So you'd say that. Then you may want to go into the medication section to add something, to add language effectively saying each person living with HIV faces unique struggles. One medical regime may work for one person but won't work for another. Physicians and their patients really need the freedom to try as many commonly accepted HIV medications as possible, and they need to have the flexibility to switch when it's becoming clear that the patient's HIV is non-responsive to a certain treatment. And what you would want to do, if you have any of the paperwork, you'd want to try to include that. So you might want to try to include the physician's request for a certain medication for a patient, as well as the insurer's response so that you can show either that there's a really big wait time or that the insurer is saying, no, not really providing a good reason or not really providing a way for the physician to appeal. May even want, if the advocate is sending this, to get letters of support from those physicians, although obviously if you're the physician, you can modify it to say this is really disrupting my practice as somebody who is trying to adhere to the standards of care for my HIV patients. This strict prior authorization is really preventing me from delivering appropriate care.
Great, thank you, Carmel. Another question here, a little bit about Medicare Part D. Someone's curious if there are any willing provider laws that apply to Medicare Part D, managed Medicaid, as well as traditional Medicaid plans.
So there are any willing provider laws, and they vary from state to state. So it would be difficult for me to say, to give you a blanket statement saying, yes, like your any willing provider law will really help you in this situation. I do know that in some states the language is really good, and what an any willing provider law says is basically if there's a pharmacy willing to agree to your terms, insured, to be part of your network, or to play as if they're part of your network, you have to allow them. And so, for example, Massachusetts has that language, and that language has been helpful for certain pharmacies to either come to a settlement with insurers about getting carried and being part of the network, or to start sending letters to regulators saying, hey, we're willing to play by the terms of any one provider law, and they're not allowing us. So if you're interested, please give me a call. We have a database of any one provider laws, and I'm happy, especially if you give me a day or two notice, to look into them and to help give you advice about how they may impact your regulatory complaint.
Great. Couple questions here about the slides and your contact information, Carmel, but I will say that at this time we don't have any other questions, so get those in as soon as you can if you do have any questions or any points that you just want some clarification on. But a question here about the templates, where they'll be posted. So they will be posted on the website hivhealthreform.org. You can also download them. They will be linked in the follow-up email that you'll receive having been a participant on this webinar. And we will also push it out again through the website hivhealthreform.org, which we encourage you to visit often, not just for these templates, but again, all the information that we have up there around the ACA and its impact on the HIV community. So that is where you can find those templates. And then also, Carmel, could you give your email contact info? We will, again, we'll provide that in the follow-up email as well, but if you wanted to state that, oh, it's up on the slides, but if you wanted to say that out loud, that'd be great.
Sure. So my email it's a little bit tricky to spell, but it's C as in Charlie, S as in Sam, H as in Harry, A as in Adam, C as in Charlie, H as in Harry, A as in Adam, R as in Richard, at law.harvard.edu. And again, I really welcome any emails, any inquiries. I'd love to talk to you guys and help support you to craft really strong regulatory complaints, because I think that putting a lot of pressures on the state regulators will result in some really promising results. So it's definitely worth a shot to send a letter.
It is. Another question here. So this is from a participant. So she says, we've been trying to get a liaison for individual marketplace insurance companies. And she's writing as someone from a co-pay assistance program. Is it true that only agents and brokers are able to get these, as we've been told by insurance companies?
So I haven't heard anything about needing to be an agent or broker to have a specific liaison. And to me, that doesn't seem right. There isn't really any regulation around that. So what the insurer charitably, the insurer may have confused the liaison with, so only certain people are allowed to offer enrollment advice, and those people are insurance brokers, or they're people in special programs such as navigators. But there's no reason why a health insurance company shouldn't be able to assign a specific consumer representative to work with a nonprofit or co-payment program that they know enrolls a bunch of their members in the plan. So I would, unless there's something very specific in your state's insurance laws, that sounds like you might be given a little bit of misinformation.
Great, thank you. A question here about using the templates, to raise issues for folks who are co-infected with HIV and Hep C, and if these templates could be used to raise issues about access to care or meds for these individuals who are co-infected.
Yeah, absolutely. So the current template is written just with HIV in mind. But first of all, there's no reason that just because somebody's infected with hepatitis C that the letter doesn't apply. If there's still a person living with HIV, this letter still applies to them. If it's a specific issue related to their co-infection, if there's some sort of care they aren't getting because they're co-infected, or if the issue lies in access to their HCV treatment, then give me a call because we don't yet have the HCV template ready to go, but I can work with you to modify the letter to reflect the fact that even though they're co-infected, they may be getting the HIV treatment they need, but they're not getting the HCV treatment they need, and how to bring that up.
Great, thank you. Great question here. Would it be useful to CC complaints to sympathetic state legislators?
Yes, absolutely. I think that sympathetic state legislators would love it because then they'd be able to call up the regulator and say, my constituent sent you this letter. Have you responded to it? What are you doing about it? So I think that it would be great to send it. Also, a regulator may see that you're sending it pretty widely and be like, oh man, there's going to be some eyes on us, so we really do need to respond to this letter and pick up the call. So especially if you have somebody who is really good about these issues and really sensitive to the HIV community, then I think it's absolutely worth CCing them. Basically,
another question here about
trouble.
What's that?
I was basically saying, like, be tattletales, get them in trouble. They're not doing their job. They're not protecting consumers, and so it's good to let them know, eyes are on you. You better do what you were put in place to do, which is to protect the average voter and citizen in this state.
Exactly. Another question here about the use of the templates, a little bit to what you spoke to earlier about sort of adapting a letter for Hep C complaints. Could that also be used or done for mental health and substance abuse and denial of coverage?
Yes. So mental health and substance abuse, as many of you know, does have specific parity laws that are included in the ACA and have been implemented in regulations. So I think that we could modify it to create a pretty strong letter also incorporating that. So we can discuss offline how to do that and how this letter, the flow of it can be changed to reflect the requirements around mental health and substance abuse services.
Carmel, could you speak a little bit to some of the partners that we're working with and that you're working with on these issues, getting these complaints written up and submitted, other maybe organizations or folks in other states? One of the examples provided is change.org, and whether we're sort of using these avenues or these other sort of mediums to amplify our voice on these issues.
So I'm not sure I understand the question. Is the question how to coordinate these letters with what other organizations are doing?
I think just curiosity about if if we're working with organizations like change.org to get this information out and maybe, advocate more individuals to submit complaints?
So we don't have a specific partnership with change.org. We are reaching out to as many people in the HIV community as we can and trying to get out information about these templates as widely as possible. We will be doing a little bit of a campaign, sending out an email with this information next week to people who we think may benefit from it. If there's an organization or a person that you think would be especially relevant and could really take this template and run with it, please let me know and I'll be happy to make sure that they get a copy of this information.
Great. Well, at this time we do not have any more questions. So I want to thank everyone who joined us today, especially Robert and Carmel. Again, I encourage everyone to visit hivhealthreform.org. You can download the slides from the webinar. You can listen to the recorded webinar that we've done today. You can access and use our Speak Up reporting tool. And very importantly, download the templates that we've discussed today. So with that, again, I thank everyone for joining us, and I hope you all have a nice afternoon.